Welcome everyone. We just finished a very productive session where 6 entrepreneurs presented to the CIOs. Now we'll have the privilege of listening from these experts and leaders, their viewpoints on what's keeping them awake. So I think the thing that we'll ask is, where do you see the gaps today, and any particular trend that you like to highlight? So let's start with Marty.
Well, that's a loaded question. Gosh, there's tons of gaps. Some highlighted by some of the vendors today. I think that they obviously the entrepreneurs are getting close to what the big challenges are. I mean, gosh, I think we all would like to solve their interactions with the payer community. There's a lot of emotion and a lot of legacy kinds of things in that space, but there's lots of opportunity. I mean, I think if you step back and look at the waste of money in the health system, a lot of it sits between the providers and the payers, and there's certainly got to be a different model than the one that works today. For HCA, and I'm sure it's true for the rest of the group on here, it's about how do we get a greater grasp of our data, and how do we use that to, really create, actionable insights. I think that, we've decided to make an arrangement with Google, and working towards, trying to, I tell people that, before Waze, we had real-time data back then too. It was called brake lights. And in healthcare, we still make a lot of decisions based on brake lights. And how do we get that real-time data so that we can help somebody, an hour or 2 hours up the road to make a better decision? So I think that's kind of key, and I think that the other gap is, we have a very mobile workforce, and how are we intelligently converging different capabilities onto mobile platforms, and moving away from the desktop and the laptop mentality, and really putting technology in the hands of our caregivers in the best way possible. And gosh, there's probably about 40 other items that go on the list, but those are a couple. And I guess the digital patient journey. I mean, I think some of you heard when in their previous conversation, I had colonoscopy done this morning at our facility, and so I get a firsthand look at how all that works. And there's some good efforts going on, but it's still clunky compared to other consumer types of experiences we all enjoy. And so a lot of effort still in that space.
I hope you were knocked out during part of that time.
Yeah, they managed to take care of me extremely well.
All right. So I'll refrain from asking any question right now. Let's just go to Craig.
Yeah, I thought these companies were very diverse, all kind of tackling something different. So I appreciate the variability in that. The thing that I think is the most underutilized resource in healthcare, like the last guy, Josh with health, was really the patient. So I was kind of trying to drill a little bit more about self-service and moving some of that commodity-based work into the hands of the patient. Similar that we've seen in finance with banking and retail and some of these other verticals. Is I do a lot of that clerical work myself, and I enjoy it. But they put guardrails and give me tools that are very intuitive and easy to use. And as opposed to like, quote unquote, helping the provider, I think the biggest help would be allow the patient to do more of that work and give me the right tools with the right guardrails around it in order to make some of that stuff kind of happen. So I really think it's a underutilized resource in our whole delivery model. I did actually like, and Kash, this is my first time meeting Kash, but he works with a former colleague of mine. So I think I'll get to know him a little bit more, but drilling into the subtle medical, I think it was interesting. I like that the part of, some kind of longevity of some of these investments, these big investments that we make. And, I see it in our capital committees pretty much every month, all this reinvestment in a lot of this medical equipment. And I think if we can extend that life at a lower cost, we can not only give the provider what he or she needs, but also lower that outlay that should eventually over time, work its way to our, the premiums and or to the patient on lowering the cost of delivery. So I really liked how they could potentially extend the life of some of this really expensive equipment, and that in many cases, the ROI is absolutely zero because there's no return on just replacement equipment. It's not like you're all of a sudden going to attract a bunch of new patients because of that. So I really like that piece of it for me, because we have a lot of investment in medical equipment. I think that's a big opportunity.
Great. Let's hear from Kash.
Hello, everyone. Thanks for the time. This was good. It was interesting, and the variety was good. I sort of too, I sort of had to react. The subtle health and health note are onto something, and I sort of had to step back and think about, what is it that we're craving? Is that break in that business model? We talk about the payer interface and the provider interface and how they've done business. That's really been challenging, for systems like ours to get claims data, to get provider data, payer data, to get our clinic. New Jersey is a complicated market. Everybody's relatively self-employed. To try and form those relationships and figure out a model that works has been challenging. And the other part I want to sort of flip to is for a long time, with Google and Amazon and Hackensack just announced last week, by the way, we're standardized on one of the first early healthcare systems to move to full Chrome OS, right? And so I'm talking to you on a Chromebook. We have Chrome in our background. It's Google Workspace everywhere. We can have a conversation another time about that. But reason I mention it is all these organizations have talked about that patient experience thing, right? To sort of create an Amazon-esque experience. I want to see my doctor. I want to see them now. I want to know how much it's going to cost. I need my medicine now. I want to press a button to, that seamless app access. And nobody's fixed it. Nobody's, got anywhere what I wouldn't say close to fixing it. I mean, I saw Health Note, and I'll give them credit for trying, but I personally have tried in my own world, in prior world. It's complicated. But that is, I think that if I had to sort of lay it down for entrepreneurs, I think that's the goal that's still worthy to go after. And I would be closely watching that space for sure.
Great. Thanks, Kash. Okay, let's go to Sam.
Yeah, just building on what Kash was saying and Craig, that the patient is definitely in the middle of all of this, and getting the full picture for the patient in their medical chart in interoperability, right? We've tried health information exchanges. We've tried interoperability between Allscripts, NextGen, Epic. We're the big ones, and we are still so far away from a standardization of interoperability. And I think that is something that would absolutely throw us into the future in healthcare. We look at things like organizations like SureScripts. We have a pretty good national HISP-based pharmacy organization where the payer information is coming in, the provider information is coming in, and we're able to provide the patient the opportunity for the cheapest drugs, prior auths, all those wonderful things. But we can't seem to get it for the patient chart itself. And we got to meet the patient where they are. Not all patients have the ability to pull up their MyChart app or any kind of patient portal to remind themselves what their last provider said to them. Or, some of them forget that they've made notes on the medical issues that they're seeing today. And as we get older, we see multiple specialists. It's the nature of the beast. And I think having some kind of standardization in that realm is really going to help us. And during the pandemic, one of the things that came out, the Cures Act around information exchange protocols, is a really good base to get us to where we need to be, where we can't block information exchanges. We have to give the patient their information, but I think we need to take it that step further and decide on a national level to meet the patient where they are and share that in a national exchange in some kind of sense.
Great. Thanks, Samantha. Finally, Sam.
Well, I think it was a good, diverse group of people coming in today. So I think I should applaud you and Deepthi and others to kind of attract these people to come and talk to us about it, right? So I think pretty good point.
Stan, sorry to interrupt. If you guys are willing to come, there are plenty of entrepreneurs very keen to present to you guys. So getting you guys is a bigger challenge. Entrepreneurs will knock on our doors.
Yeah, we'll happy to do whatever is needed, because I think this this kind of innovations is needed for us to solve the problems. So probably all in there. I'm pretty much like Kash. I think I was intrigued with Shuttle Medical and Health Note. I think both these companies have a good concept to really take it forward. I think the things that I worry about at this point is there are a lot of point solutions that people are kind of bringing together, right? How do we interoperate with these point solutions? And a lot of health systems are struggling with that, because you have to create an operating environment where everything can operate well. And the more the number of point solutions that you have, the more difficult the operating model will be. And I think that's something that many of these startups have to understand, right? Saying, how do they operate in the ecosystem? And it's hard. It's a hard thing. And I'll also say this, one of the biggest challenges, I think with Kash kind of hinted at, very simple thing like patient navigation. We have not solved for that yet. We all keep talking about it 10 times in a day. That bothers me as an individual. That bothers me. Patient navigations, we have all digital front doors, doesn't solve the problems that we have as health systems. And I think really trying to figure out who are those brave souls who are taking that as a problem to solve, because to Samantha's point, navigations become more and more difficult once you become more aged, right? When the patients become a little more aged, Medicare patients, they have different kind of navigational needs. And I'll say that I'm the first to admit that we have not solved that as a problem for the industry. We are not even close. And Venk, to your question, the reason I stay engaged with this is my desire, my curiosity to know and to see if I can help to get to those points. That was my finishing comment.
No, this is awesome. I think this is a great sort of overview. And now we'll open the floor to questions. Please send the questions either on the chat or on Q&A, and we'll ask them to see as they appear, if they are not repetitive. So there are two questions right now. One is from JJ Singh, and his question is, how can SaaS vendors work with internal IT to shorten the evaluation, contracting, and implementation cycle? It takes up to a year currently. So any ideas, any suggestions? Any of you?
You know, I think all of us are going to say, when you figure that out, please tell us, because we'd like to. I think that's where the pause was. I think every organization is different. If I had to, I've been on those shoes a couple of times, and honestly, my experience, my guidance would be, you know, come prepared. Many times I speak to startups that we want to do business with, but they have no clue around security. They haven't done a security assessment, for example, right? They haven't done a profile that the procurement team would want to understand. So it's almost like they're doing it for the first time, which is, I think, where it takes a really long time. So if there is any way that they can either go through that process as a dry run somewhere, or say, look, we've done this with other organizations and here's sort of the pre-work, I think internally that helps the organizations go through their own internal processes. But it is a sequential process, unfortunately. I don't think many organizations are that automated, but having the pre-work done and not being the first in the door, especially with a large organization, because they don't understand how to work with startups. So that's how I would think about it.
I have a couple of things to add on to that. I think it's a great comment, and everybody is going to be a little bit different. I would say there's two things. One is when you work with some of the healthcare systems that have an investment arm, and they're an investor in you, making that connection, that network. There's so many people around the country that I trust. If they're making an investment as a health system into you, that probably weighs a lot for me in making a quick decision. And or if somebody that you're using, again, kind of peer-to-peer, use that. I use the network tremendously. If I got one or two people who I trust, colleagues of mine, and they got you in place and give me a use case or something like that, I can quickly bring that up and get it going. So I would almost, don't try to like hit a home run, but come in with something, a very specific use case, small, easy, fast to get done, fast to get rid of, fail quickly as well. I think there's many of us that are very interested in those kind of relationships. And then once you get a hit, then you can continue to expand the relationship. But to get that first hit could be just use the network, to connect people together, see who's working with who or talking with who. And I think you'll find yourself be able to progress left and right pretty quickly.
But I would, I think Kash was right on target. Is that, we're going to be hypersensitive to security. We're going to be hypersensitive to high availability. We're going to be super sensitive to scale. And so those three things are usually the last things that startups think about. I wish I had $1 for every time someone became involved with us and somewhere along the path they looked at us and said, gosh, you guys are really big. Well, yeah, we are, and you should have seen that up front. And so it doesn't stop us from doing proof of concepts and flushing things out. But gosh, we don't like killing small companies either, but we do a lot of it because those three fundamentals aren't traditionally baked in to the beginnings of a startup, and they could help themselves by stepping back and go, hey, what are the foundational pieces that if we're successful, we have to really hit a home run with? And it's usually those three things.
And I will add,
Marty, can you repeat those three things again?
It is security, having the proper security controls in place. It's high availability. Is your application built to be redundant, resilient against disruptions? And then, the third is, can it scale to, we have 2,000 sites of care, and that's like a gold mine for a startup, but yet typically their architecture isn't, even if they're cloud-based, it is not still architected for the scale needed.
And I think I'll add to what Marty said. I think there is also might be helpful to come in as a trusted advisor to really kind of educate in terms of how the budgeting has to happen. Because many times from a SaaS product perspective, there is a little bit of understanding in terms of what goes to capital, what goes to operating expenses, what has to be maintained, what is the maintenance cost of all of that. So coming with a trusted advisor hat, and basically talking about this might help to accelerate some of those processes as well.
Yeah, and following on from what Sam just said is, contract and implementation and evaluation are all just part of the process, but coming in as a partner to the organization will help understand all different facets. Advantage Care Physicians, we have 40 medical offices with multiple specialties. I heard Marty say they have over 2,000, I think he said. So, understanding your client prior to going in and just be realistic with your expectations on how long it can really take, because procurement, InfoSec, and the current climate with cybersecurity and ransomware, it has to be the process that we go through to make sure we're both safe.
Okay, I have a question before others ask the question. How do startups get in touch with you? I mean, if they think that they have a hot product for you, is there someone in your organization that you have dedicated as a gateway, or is it all everyone has to figure out their own way of getting your attention?
I can see everyone smiling because I am sure they all get multiple calls a day because their phone numbers out there, and it's, you're getting calls from lots of different startups, and I personally get a little bit fatigued from the constant calls. I would say reach out over email and LinkedIn, and always provide a little bit of an information blurb of what it is that your company can really do, so that we can be polite enough to say we have that, we don't need that, we do need that. It gives us very quick expectations if it's going to be worth our while even partnering. But I'm pretty sure the other gentlemen on this call can agree that the number of calls are a little bit insane.
Yeah, I would agree. Don't do any cold calls without any personalization or a reference of somebody that you worked with that we may know. I bet you, I mean, my spam list is huge. If I get 30, 40, probably every day, I just go straight to spam. If you're sending me something I never heard of you or of your company, I'll never get a message from you again. So I just go straight to spam. And that's probably a good thing for me. But the other thing I haven't used LinkedIn a lot in terms of messaging, but sometimes when you just kind of read the one sentence or I just delete them, and there's something in there that I know that you did a little bit of research or you reference somebody, or like in the case of actually a company called Syllable, New York Presbyterian was an investor, Houston Methodist, Ken down there used them as a use case. And now we're looking at 5 or 6 products, but they're great, a great company. But that's because it came from somebody else, not necessarily straight from you to me. So.
And also, many states have, New York has one, which I was part of, the E-Collaborative, and the Penn, the health system, has this, center called Penn Innovations, which is the Penn University's Center for Innovation. What I suggest to startups is go to each state body, city bodies, and find these organizations, just like TiE. There are many organizations like that help carry, the water for you. Don't walk in the door cold. If you connect with LinkedIn, 9 out of 10 times are going to ignore it. So walk in the door with somebody right? And then if you don't know an individual, find these organizations that we'll do a forum like this, we'll host an open day like this. Remember, going cold calling to a CIO or anyone who's not interested, they're going to say, but you're better off going to a group of people that are open to listening, just like we are, right? We're listening here, we're open to listening to ideas, we're in this forum. So there are organizations around the country that help connect the dots. I would focus on finding bridges to those organizations.
I'll also say that making it a little more contextual. So basically, wherever you are trying to get in, there's a little bit of background information and context that probably is needed. And spamming many people within the org may not help because, it's just the kind of psychology that plays out, right? But I've always seen that if it is a little more contextual, to Craig's point, that might help to kind of, have a person network with and then take the message in. So you pretty much have to find a cheerleader who understands, who is kind of having that problem. And typically, folks like the strategy officer or somebody who manages innovation or digital or stuff like that, or CIO, those people might be able to take that in with the right context.
Great. I want to hear from Marty because he probably is the biggest target to see for every healthcare entrepreneur who wants to sell something to the hospital groups.
Well, I chuckled because, like Sam said, we bump into from so many different angles, not just email and LinkedIn. It's just even our own organization. Just like I gotta feed through just our own division, sending ideas and thoughts. We have a strategic assets group that focuses on technology. And I do think that eventually, I think the company will find itself in a place where not only does it have a better mechanism to evaluate, but also be more an investor itself. I think that, we just sold one of our companies to General Catalyst, and I think I'm hoping that's the beginning of us building, a technology portfolio of products that we use, and at the same time have an investment in the company as well. But that's how we kind of use our strategic assets. And honestly, I think our partnership with General Catalyst is going to fuel a little bit of that as well. So, but the jury's still out on that, but it's a maturing process.
Great. Okay. I have a question from here, and I don't know if you guys are familiar with that product at all, but the question is, what do you think about Truveta's, TRUVETA's approach to democratizing data access?
Wow. Did you hear my chuckle? I'm sorry if you did. I didn't mean that. I didn't mean that to be as vocal as, hey, I admire what they're trying to accomplish. I really do. But, and we've had numerous conversations with them, and I just would say they are underestimating what it takes to normalize. It's hard enough to normalize data inside of our own health systems, much less to normalize it across multiple health systems. And I'm not convinced yet that they have the firepower. I mean, I think they're fueled by a bunch of ex-Microsoft execs. I'm not sure they have the firepower. And I think if it's going to be solved, I think one of the big guys is going to have to take it on. Maybe some of them will have and we're talking to them. So if other people have a different opinion, I'd love to hear it.
We're talking to them too, and talking to many companies. And one of the reasons I joined Hackensack, I've only been here 2 months though, right, is to create a data solutions strategy approach. I have the same reaction. The real question becomes who owns the data and who's benefiting, right? There's a lot of these Flatiron-esque companies out there that have made them monetize on this thing, and you give them your data, and then the whole indemnity thing, et cetera, et cetera. The engineering of putting it together is, it's possible. I would wish, going back to something that Sam said earlier, I wish the government would get involved and, create a trusted third-party source. Because if we went in that direction, the payers, the providers, the farmers would all start to contribute in a safer way, and then we'll have the denominator of data that we're sort of really after. And Truveta's trying to do this commercially. There's a lot of trust issue, there's a lot of quality issue, there's a lot of indemnification issue. And I know the organization I'm at, we're going to watch and see what other customers of theirs do. And Microsoft tried this, right, with what was it called, Catalyst Health or something? What was it? And Health, thank you, right? They abandoned it. Google. I remember I spoke to the CEO at Cleveland Clinic, who, when he was at Google, and I just spoke to him 2 weeks ago. He's a family friend of our org here, and they were saying, "Oh, let's just build another EMR internally." But when they went to experts outside, they're saying, "Well, that's not so easy anymore, right? Because Epic is now everywhere. Nobody's going to fund buying another EMR." So I think there's some real barriers to, but I'll give them credit for trying. And as an organization and as somebody who's interested in data, I'm definitely interested in watching and learning.
Hey,
I will say this. We have done an initial principal partnership with them, but it boils down to a question about the data strategy itself, which is where this whole conversation is resting at this point. And I don't think we are very clear in terms of who owns data and who gets benefited from that. But many health systems have lined up behind them with the promise of what they can solve. Yeah. But they are not alone in this game. There are companies like Dandelion. There's another company which also is in the similar space. So I think that brings a bigger question in saying, who is coming in this with what objective in mind and what they can solve for us? So it's a question to be unpacked.
Oh, I know Dandelion quite well, by the way. So.
Hey, Marty, if you want to reach out, I actually was part of the original. We were part of the original 25 when they narrowed it down to. So I know the whole Providence piece of how it got started and some history. And I think one of the other companies that opted out toward the end said, basically, so we're going to pay you money and invest in this new thing that the advisory board kind of took over, and we're going to go ahead and sell it out to create the pharma to create some drugs that I have to turn around and buy back again with no discounts or anything of that nature kind of built in. So it's got a little cyclical kind of thing to it. And I think it had a 5-year ROI on it. So it was very long play, and a lot of variability can happen in 5 years. So interested. We took it actually to our investment committee of our board, who said we're already diverse, in our investments. We don't need to it seems to be a little bit riskier with the return than some of the other things that we're doing. So.
Samantha, do you want to add anything?
Thank you. Have any more grenades you'd like to throw into the room?
The questions are flowing in. Samantha, you want to add anything to this?
Nothing that the other panelists haven't already spoken about. At Advantage Care Physicians, we had built our own internal data lake just because we wanted to punish ourselves. So we haven't experienced too much interaction with Truveta.
Okay.
Well, Samantha, that's the interesting part. They've approached HCA when we've done it for our 200 hospitals. We have our own data warehouse, and we're kind of asking ourselves, and what's the value to us to join this? We've kind of already done this, right? So.
Okay.
Investment decision, yeah.
Okay. So another question that has come up is, how do you see CRMs like Salesforce and EHR vendors like Epic, working together in your environment?
So
we actually have both. Sorry, go ahead, Sam.
So I can take this because we are right now in some kind of a process with them. We are actually have moved quite a bit. I will say this, that just looking at Salesforce Health Cloud's roadmap and the plan that they have, they are trying to make a lot of strides to work with the EMR companies, specifically EMR like Epic and Cerner and others. There's a lot of work to be done. I think the key question becomes that who controls what in this game, right? Epic can change definitions of what they exchange with Salesforce. So think about an environment where you are building all these bridges and connectors with Epic definitions of things, and then the whole stuff on the Epic side changes, right? And they can change without any notifications, right? So the question that, I think the bigger question that from a Salesforce perspective is, well, they cannot make this agnostic to Epic and Cerner, but who controls these tokens exchanging between Epic and Salesforce, and how does that long-term play? So a lot of health systems that are investing at this point of time have these open questions for Salesforce. And that's a question which have not been completely answered yet, because Epic is working on certain other things as well, which may kind of long-term impact the integrations with Epic and Salesforce. So right now there is a path, but how the path is going to manifest itself in the next 5 years is to be understood better.
Right, and there's a fine line using CRM tools for marketing purposes to patients, right? We don't want to overly market our current patient population between all the notifications they're already getting for appointments and test results and all that good stuff. But at Advantage Care Physicians, we do use both Salesforce and Epic, and they're not integrated, unfortunately. We have two kind of separate processes, and Sam, like you were just saying, that needs to be solved. Because the process ended up becoming, what is the patient journey through Salesforce? As you know, for flu season, what do we want to share with our 65 plus, with our pediatric patients? You know, you can build all of those in Salesforce, and those are great for the patients because it's constant, consistent journeys that they can go through. Advantage Care Physicians can communicate, and that doesn't end up in Epic. So we don't know how many times the Salesforce component has hit the patient before they make the appointment, and that speaks into data analytics as well. Like, we don't have that consistent piece that you can put together. There is useful tools in both, but yes, if any entrepreneur has an idea here how to fix that gap, or if anyone from Salesforce is on the call, that it would be wonderful to be able to integrate them. Epic does have their own CRM tool, but I think it's got ways to go to compete with something like Salesforce.
I was on the advisory board for Salesforce's product for about 2.5 years. Now, this is 5-6 years ago. We were a big customer. I was in New York City at Mount Sinai, and totally agree. An awesome product, but it's all independent, doesn't really integrate tightly. We talked about interoperability, and it's all been tried. They didn't have FHIR at the time, but they do now, and they're doing their thing, but their sort of motivation is very different. Their motivation is, selling selling subscriptions, right? This is sort of their model, and it isn't. I don't know if it sits correctly in the world of healthcare. And But one area that I'm seeing, which is sort of CRM offshoot, that is at least getting a lot of interest in the places I've been, is conversational AI. And so there is a very interesting sort of, when the Health Note talked about the sort of Q&A questions, conversational AI, the bridge between the sort of CRM static questions and the patient engagement experience questions, there's a lot of companies that have spun off product teams that were in Salesforce that have spun off, that are creating companies that are doing that. And I think that's an area to watch out for.
Okay.
And I think the other thing that I want to mention here is that there are ONC rules coming, right? Which is, there are rules that have already been put in place, which is interoperability rules that will be kind of coming into effect from January of 2022. So Epic has, public APIs, private APIs, and private APIs, which will supposed to become public because of the ONC rules. So that will also change the way Salesforce and Epic has to work longer term. So Salesforce has a pretty well-defined roadmap in terms of what they want to do. But again, to my point before, this interoperability has to be something that has to be figured out in terms of how that whole thing settles down and who controls what.
Actually, this tickles on the use case I referred to back during the vaccines were just being released. We had a waiting list of about 180,000 people. How to contact them other than manually. That's when we used this company, Syllable, which got rooted out of Google. The founder did, and we end up capturing that list, bringing it into Salesforce, used Syllable for the contact piece, and then we integrated it back into Epic. And within 3 days, 180,000 went down to 30,000. They all had scheduled appointments. The other 150,000 already got their vaccine through. People were on 3, 4, 5 waiting lists. That all happened within 3 days and just saved a tremendous amount of man hours. That's what kind of got us excited about taking the Salesforce piece, probably adjuncting it, like in this case with a third party, but integrating it back into Epic was actually very useful.
Great. Moving on to the next question is one of the entrepreneurs who presented. So, and his question is, do you have any plans for digitizing your workflow for better patient outcome in terms of giving tools to physicians for better diagnosis and treatment?
Yes.
Yeah, I guess we'd all say yes. I mean, I think that's a part of all of our objectives. HCA probably has a unique approach here. I think we owned a separate company called Patient Keeper that we just sold to General Catalyst, and their subsidiary is called Commure, which some interesting technology about how do you create almost a sidecar that on a screen or on a mobile device that stays in synchronization with the EHR, so that it can present, independent of pumping it back through the EHR, insights, whether you're providing, nudges, whether you're providing, easier ways to work through a workflow. Even if you wanted to include, information from a payer, maybe a payer in a certain clinical setting wants to present something in context to the physician at the moment of action. And so I'm not sure it's going to work. I'm sure it's going to work, but it's a concept at least that we're looking at to try to improve the overall experience. I think getting back to some of the companies we saw today, I think that with like Health Note is how do we take some of this documentation pressure? Before COVID, I couldn't go to a cocktail party without a doctor jumping on me about how much time they spend doing documentation. So I think we've got to find some solution that takes care of the payer side of the commitment, but at the same time allows us, a physician, to create a note that really truly tells the story of the patient, so that subsequent physicians can pick up that care and do it really effectively.
I will say I presented to our board 2 years ago the nuanced DAX product, the ambient clinical intelligence. And we have that live now in certain parts of our, a couple of different states. And one of our board members is the CEO, he's an MD and the CEO of a large health system, said, thank you for doing something for the providers. So I do think the physicians certainly over the last decade have felt a tremendous amount of pressure and financing and all the different pieces. They've hit pretty hard. So as you start to transition some of that and making their lives certainly a lot easier, I think there's a lot of nice opportunities to hopefully do that. I do think, like I said before, I think moving a lot of the physician workload downstream, even as far as to the patient, do some of that work, I think is important to relieve the burden. But the burden that they do have, I think there will be some more, hopefully there'll be more, some tools going out there to move in that space. My middle son is actually the chief resident for internal medicine at the Cleveland Clinic. We have great discussions about what he is seeing and teaching and training and being trained to practice in the future. And it's a lot different than a decade ago, that's for sure.
I think the other aspect is how much time a provider really has to spend time on a tool and what has to be done pre-visit and what can be done within the visit as well. So I think there is a whole angle of provider adoption across many systems. And this is all people, right? At the end of the day, providers are all individuals, human beings, right? And we are getting down to 15-minute visits, some of those visits that happens today, right? So it's about also figuring out in terms of how much time a provider really can spend on a tool, and is there a better way to kind of push it out in a way they can consume it while the visits are going on. So I think some of that is really top of mind for at least systems like ours, which nuance is something that we adopted as well, Craig, and some of that will be addressed by that, but we still need a little bit of better clinical DSS that can push things out when the provider is in the visit itself. And that's an opportunity, to be honest.
Great, great.
I think a good baseline for having these workflows automated for the provider is what Marty had maybe mentioned previously, which is having the data there, claims data to suggest a diagnosis code or close a care gap, all those predictive analytics that other organizations out there like Lumeris as an MSO from the payer perspective, they have all these predictive analytic modules out there, but there is an interoperability component for it to get into the provider's workflow in order to make their life a little bit easier. And you can use base functionality and the EMRs like Epic, best practice advisories and, flashing yellow in the chart that's like, this person probably has chronic kidney disease. You should check that out, and help out the provider kind of decision support. And clinical decision supporting tools are definitely something that needs to improve.
Great, great. Thanks a lot for this. I do have one final question. Well, there is another one. So question is, okay. So the question is, in your organization, who represents the voice of the biggest component of your clinical workforce, which is nurses? And how close is that voice to actual frontline pains?
We have a chief nursing officer, a chief medical officer, the presidents of our hospitals report up to that org. So I say we have a pretty close relationship to the front line from a senior leadership team.
I mean, it's at the end of the day, and I'm sure I speak for everyone else, it's a top priority with the staff shortages, dissatisfaction, everything that is pressing down on the nursing community today. I think we obviously we have the same kind of structure that Kash just mentioned, and it does its job. But we've got Six Sigma teams out there looking to try to improve. We did a nursing hackathon last year just to try to eliminate some low-hanging pains for nursing. And so I think the whole nursing area is another area kind of ripe for innovation, because I think I don't think people like to admit it, but there's tremendous variation in how nursing is performed and how it's executed. And I just think there's probably some technology opportunity there that hasn't yet been tapped into.
Yeah, I will add that not, recently with COVID, really with what we are going through, the frontline pains that the nurses have, it is not getting translated immediately for anybody to act on it because they kind of, it's that frontline people keep that with them for some time and then, so there is an overall cultural thing here saying how much they can deal with and how much they have to share because they know that some of those things are not being able to be solved. So just to the last question part of this is, well, the voice is pretty big, but not every time that is completely representative of the frontline pain because of the situation that we are in at this point.
At Advantage Care Physicians, we have 3 clinical vice presidents who do still practice patient care, split between clinical workflows, clinical training, and population health management, who are on the front lines themselves. And we meet with them frequently to discuss these frontline pains and try and implement technology solutions to help them. And it when it comes to a system like Epic that's very heavily workflow driven, how can we push out the PHQ-9 prior to the patient visit? It makes a huge difference to the nurse's day if the patient just does that at home before they come in. So we try to stay really close from a technology and clinical point of view.
Oh, great. I think we are approaching the end of this panel. So I'd like to end up, with a fun question. And the fun question is that in other industries, I have seen how the greater importance of technology is moving the CIOs and the technology leaders closer and closer to the center of real power in the company. And I'm wondering if that's happening in healthcare or not, and how's that happening, or is that happening fast enough?
Well, it's absolutely happening here at HCA. I've been the CIO for 10 years, and typically, we've been fortunate that the IT organization has grown at the same rate as the rest of the company has for 9 years, but that all has changed here for 2022. Company just steps back and has asked itself, how do we really change things? How do we really differentiate ourselves? And just like our CEO said, you can only build so many more hospitals. And he said, when I step back and think of the investments we can make over the next 5 years, technology is really at the top of the list. And I just spoke to our board last month and outlined that, we are, tripling the IT budget, and which puts a lot of pressure on us. I'm not sure that's good or bad news, but the fact is, there's I think I think all of us would probably say the credibility of IT and healthcare organizations has really climbed over the last 5 to 10 years, and I think as people see the work that we've done, they see the possibility, and so whether it's data mobility or even basic things like automation, all those things are on the table, and they're winning the decisions between other capital investments that traditionally would have beat us all the time.
Okay.
Yeah, I will agree with Marty. I think technology is really being valued, as well as I think there's a lot more realization that technology can take a health system to the North Star in terms of whatever we have defined. But again, there is also a lot of priorities within any health system, right? In terms of prioritizing those and ensuring that the technology spend still happens is a constant conversation all the time. And I think that's a good, healthy tension, right? When you really put technology in the middle of everything and then figuring out what else can be done with the money that we have. And I think those things I've been seeing for the last several years, which I think is a very positive thing. Also, the thing is that at the end of the day, the North Star is not well defined. There is always a finish line is not the finish line that there is always a constant churn in there, which basically creates a different kind of a need in terms of the funds that you need to get there. because what you have planned yesterday may not be true that you need for 2 years from now. So I think there is a lot more appreciation of those things in the leadership and the board, which makes it a lot more progressive compared to what I had seen 10 years back or 7 years back.
Yeah, I think Sam said it well. Technology has always been, whether you're talking about data or digital or innovation or transformation, it's an investment, and you got to compete that and compare with other potential investments of the company. So the fact that Marty made the comment, how many more hospitals can we invest in or build versus how can we do more things digitally or transformationally, I think is probably the stories are more compelling now than maybe a decade ago, because you're starting to see the influence from big tech as well as from retailers coming in, kind of showing or sharing different way of doing business. And so since there's a lot more consumer choice now versus insurance driving where you get your care, people do have choices. There's the things that we're doing and plan to do, and will, to Sam's point, what we plan to do will likely change a lot in the next several years, but at least from the roadmaps today really helps encourage that recruitment of new patients or consumers and the retention of those we got. And I think those are things that we'll continue to push and see. I don't think it's the title of CIO or anything like that, because when we sit around and we talk, certainly I have a certain amount of assets that I bring to the conversation. However, you got to be focusing on the business, focus on the clinical aspects of your work, focusing on the imperatives that are part of your strategy. As long as my work can help move some of those or can help others move those because they're using my tools, and that's kind of where the decisions get made.
Yeah, I agree with Craig. It's always going to be a partnership with the business to make sure that technology is staying at the forefront of the clinical workflows and patients, but not at the detriment of what it is that they need to do today.
Any insight from you, Kash?
Yeah, I've been in this team for a short while, but I can tell you IT is solidly integrated. We're in every committee, cabinet, governance, pre-board, board meetings. Every capital investment formally has to go through IT. Every operational thing goes through IT. The investment committee go through IT. So it's just a cost center, so you have to kind of go through it. But more importantly, they're coming to IT for thought leadership. And how can we, what's more important? Does this integrate with this? It's, years ago, 20 years ago, we would solve a lot of problems with people, and we just can't afford that in healthcare. And conversation becomes is how can IT help, right? How can IT be used as the leverage, the multiplier, the competitive advantage to achieve our goals? So culturally here we're integrated across the board. And if anything, my first reaction when you were sort of asking about that, my first humorous reaction was, keep me away from the light, because I don't want to go near the light anymore, right? Because it's kind of what we feel like. We're just all the time in the spotlight all the time. And it's a good thing. It's a healthy thing. And I'm very encouraged by that, because I'm more interested in how the business runs than how the IT stuff works because I have an awesome team that figured out how to keep the lights running. And I am much more interested in figuring out how the business works. So.
Great. I think this is a fascinating hour of conversation. We are coming to an end of that. We really, really appreciate and thank you for the time that you guys spared for this. So thank you again. And I hope that you also found it useful enough that when we approach you next time, you would agree again.
Certainly.
Yeah.
Thank you. This is good.
Thank you.
All right. Thank you very much. And the session is over now.